Welcome everyone. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite website, MuniMeterHealth.com. Thank you for watching, learning, and sharing on this website, which is dedicated towards the human heart and its illnesses. I thank you for your enthusiastic interest and support in my cause of spreading this knowledge freely to all and bringing about the awareness of the healthy human heart. So welcome again to MuniMeterHealth.com, your favorite website. Without any further ado, as I always say, let's delve into the subject matter, and the matter of the subject today being, what is acute AR? So let's discuss what is acute aortic regurgitation. Now, this will be on the boards, as I say to my interns, residents, fellows, and my medical students, one way or the other. So I'll just, without any redundancy, straight delve into the facts that obviously acute AR versus chronic AR must be distinguished. So the way you distinguish that is both will have a similarity or can have a similarity. However, acute AR is normally more severe. Just remember that. It's more severe. And the other thing is the LA size and the LV size is normal in an acute AR settings. So here we are drawing a distinction between acute AR and chronic AR. So just so that you know, the heart size, specifically the LA size and the LV size, will stay normal because there has not been enough time for compensations to occur. Remember, LA size and the LV size only increase in chronic ARs primarily because there's enough time to compensate over a period. And that's why chronic ARs are more compatible with life, whereas acute AR, you'll see, is not compatible with life unless you take this patient to the OR within a matter of hours to a day or less than a day. So having said that, now let's understand what is the etiology. The etiology is, well, obviously acute AR, either it's a function of a valve or it's a function of the aortic root. So the aortic root dilatation that can occur in the setting of acute dissection, for instance. So that could be an etiology which extends down into the aortic valve as well. So aortic dissection could be a major cause, or an aortic aneurysm which later on dissects, and then an acute AR to follow because there will be a retrograde aortic flow back into the left ventricle. So that's one very common cause, but it's a very important cause obviously. So the patient will have to be assessed for aortic dissection as well. Very importantly, it also occurs in a setting of infection, obviously an endocarditis. And once the endocarditis sets in, then obviously it's either the fenestration that has occurred within the valve leaflet, or it could be a perforation, if you will, or sometimes even a bicuspid aortic valve, which could be affected as a result of the aortic infection, the endocarditis, and that can lead to the acute AR. So these are the common reasons why most commonly it will be on the boards or on the exams, but obviously in clinical practice also, these are the 2 or 3 common causes of acute aortic regurgitation. Now, having said that, what is the hemodynamics? Like we just talked about the hemodynamics, obviously one of the things that you'll see is the LA size and the LV size are normal, but there will be a severity of the AR. So let's draw the heart for a second and understand it better. One sees that the mitral valves are right here, tricuspid valve here. I'll draw the pulmonary artery here, for instance, and this is your outflow tract. And this is the area in question, if you will. So what is happening is, now let's draw this in a little more enlarged fashion here. Here's your valve, and this is your left ventricle, and this is your aorta. So here we have. So what is happening is you're in diastole, when the ventricle is dilating, LV diastole, for instance. That's occurring. You will have all the blood returning back from the aorta, which was pumped in the previous systole, now returning back into the left ventricle, rather abruptly, because it's an acute AR, so obviously there's not much time to really return back. And as a result, this will be a rather drop quickly into the left ventricle. So that will be reflected or will be seen, if you will, eventually as we go along into our further discussions. So if you were to look at an echo, for instance, and you were doing, say, a 4-chamber apical view, one would see that the heart will be obviously in this position. This is your right side, this is your left side, and I'm drawing this here like that. So you have LV and LA here, and the aorta is here, for instance. So the left ventricle will be, and the mitral valves are here. This is your tricuspid valve, obviously. So what is happening is the aortic regurgitation is happening, and that aortic regurgitation is happening rather abruptly in this direction. And again, the severity, as I said, cannot define whether it's acute versus chronic AR. But what will define is the LV size. So you look at the LV size and you look at the LA size, and they are normal or near normal. So when you have a severe AR present with normal LV and normal LA, that is acute AR, okay, for all practical discussions, if you will. Another distinct feature would be that if you were to do the Dopplers, now that's basically on a 2D or a Doppler, if you will, color Doppler. But if you were to do a continuous wave Doppler, you will see that the equalization of pressures is rather to zero. So here comes the acute, like this is at end systole and end diastole. So the end diastole, the pressures will return to zero, the baseline. So same way in every cycle. So this is how the aortic regurgitation will look in an acute setting. But whereas in a chronic setting, if you were to draw the chronic setting, the Dopplers will look somewhat more like this. That means they don't drop down to zero, whereas you will have an end systolic pressure. This will be systolic, and this will be end diastolic pressure. And the end diastolic, this difference will be calculated in terms of pressure half time, and the pressure half time is say is less than 250 milliseconds, then obviously this is a severe AR. So that's one distinction. Whereas if you were to look at another form of AR where there's a drop, but the drop takes longer time. So here the pressure half time, if you will be more than 500 milliseconds, and as a result this will be a milder form of AR. So mild AR, chronic, severe AR, chronic, and this is an acute AR on a Doppler where the end diastolic velocity or pressure returns to zero. So that is a distinctive feature of the acute AR. Now, how do you manage these cases? Obviously, they're quickly getting into the management. Once you've diagnosed these patients, then you can quickly manage. By the way, a CT and MRI should be also done, CTA or an MRI, because that will define the aortic dissection and the extent and the location, etc. Because that is paramount importance. That should be marked on the boards, by the way, and as part of your clinical workup. A CT MRI should be immediately done because that will define the aortic dissection. It will also define whether it was a bicuspid aortic valve and any other features of endocarditis, etc. Now, treatment plan is mostly vasodilators, obviously, and then you use inotropes and sometimes other ventilatory support, like for instance, the patient is starting to develop respiratory failure. How are the clinical features though? And of course, these patients, they all go for surgical intervention after that. So surgical intervention should be done immediately. It's an emergency, remember that. This is one of those medical emergencies in the cardiology. I would always say acute AR. Once you diagnose that, stabilize this patient in a matter of a few minutes to a few hours. Let the CT MRI happen simultaneously. A surgical consultation is made, and a surgical suite is being immediately opened, primarily with all top surgeons to be on call, and surgical intervention is offered to repair this aortic valve and the aortic dissection. But these patients are very, very sick. Now, clinical features, obviously, which are very, very important here, I will just probably say in brief. One, you'll see, well, these patients are markedly tachycardic, so the heart rate is markedly up. They will be shocky, obviously, their pressures are dropping, and the urine output is declining. So very importantly, they are going into a hemodynamic shock, okay? For all practical purposes, let's write hemodynamic shock, for instance, here. The other features would be obviously cold, clammy skin, which we are not getting into. S2 may not be heard. Why? Because the aortic valve is not closing. But you will hear an S3 gallop. So there will be an S3 gallop, and there will be a blowing diastolic murmur, if you will. And that's a diastolic murmur I'm just drawing here for the sake of the students, if you like. And that's sometimes it's very, very short, and it's very low pitch, so it's not even heard, specifically so the patient is in pulmonary edema, because those are the other features that these patients will present. And then they go into respiratory failure as a result of the pulmonary edema because of marked hypoxia, because the PO2 really declines rather abruptly in these patients. So therefore, it's a matter of time. That's a surgical consultation should be immediately done, and patient should go to OR for valve replacement. So having defined what acute AR is, the distinction should be made between the chronic versus acute, and the etiology is very clear: dissection and endocarditis. The LA-LV sizes are normal in the acute settings, very distinctive features. The echocardiographic features are very distinctive also. The velocity returns to zero as opposed to in the chronic ARs in severe and mild. There, of course, the milliseconds of pressure half-time will define, less than 250 will define severe MR, whereas more than 500, as I said here, will define mild ARs. 2D will define the size of LV and LA, as I said, and the treatment plan is very, very supportive initially for medical it's like a medical emergency in a setting of acute AR, where one tries to stabilize the pressures and gives positive inotropy. By the way, there's a contraindication for intra-aortic balloon. Yes, very, very important. It'll be on the boards. Intra-aortic balloon pump is a no-no. Remember, it's a no. So do not use intra-aortic balloon pump in a setting of AR, acute AR, because intra-aortic balloon pumps tends to dilate. If the balloon inflates during diastole, that will only defeat the purpose of the acute AR and make things worse. So you do not want intra-aortic balloon pump in these patients in acute AR. Okay? Well, thank you for your attention. Again, welcome to MuniMeterHealth.com, your favorite website. And I'm just adjusting my picture here for a second. So MuniMeterHealth.com is your favorite website, and thank you for all your enthusiastic support. Keep watching, and we'll be back again with a new video vignette shortly, picking up another new subject for you guys. Thanks so much for your interest.